All right, welcome to this explainer. I am absolutely pumped you're here today. We are setting the stage for a rapid, highly structured clinical review of Step 2 cardiology concepts. We're going to take some incredibly high-yield information and distill it down into a clean, visual format. Because let's be real, if you want to nail the next best step in management on your clinical boards and out there on the wards, you need crystal clear mental models. And that is exactly what we're building today.
So here's our roadmap. We'll be hitting chronic heart failure paradigms, acute decompensated heart failure, high output and right heart conditions, high-yield cardiomyopathies, and finally wrapping up with pericardial disease and trauma.
Okay, let's dive right into Section 1, chronic heart failure paradigms.
First things first, we've got to contrast the two major paradigms of chronic heart failure. This is literally the bedrock of clinical cardiology. On one side, we've got heart failure with reduced ejection fraction, HF-ref. This is an ejection fraction of 40% or less. It's fundamentally a pumping problem, and the crucial takeaway here is that optimized medical therapy actually reduces mortality by stopping cardiac remodeling. Now, on the flip side, we have heart failure with preserved ejection fraction, HFpF. Here, the ejection fraction is completely normal. The issue is a stiff, non-compliant ventricle, often from concentric hypertrophy caused by chronic hypertension. It's an impaired relaxation problem. They might share the exact same congestive symptoms, but mechanically, they are entirely different beasts.
Now, speaking of diagnosing this stuff, I really want to warn you about a classic clinical trap. We all know BNP is a fantastic marker for heart failure, right? Well, beware the BNP obesity trap. BNP can actually be falsely low in patients with obesity because the hormone is cleared out faster by fat cells. So if you've got an obese patient sitting in front of you with dyspnea and swollen legs, but their BNP comes back just below the diagnostic threshold, do not let that completely rule out heart failure in your mind.
So, let's say you've confidently diagnosed your patient with HF-ref. What is your very first move? How do we build that foundational, optimized therapy regimen that's going to actually keep them alive longer?
Well, when you're building out that foundation, you sequentially add agents that dramatically shift the survival curve. For initial optimized therapy, you're looking at an ARNI, like sacubitril/valsartan, paired up with a beta blocker. Both of these slow disease progression and actively improve mortality. Notice that diuretics, like furosemide, are strictly on there for volume overload to improve symptoms. They don't give you a mortality benefit. As you move up the ladder to steps 2 and 3, you add a mineralocorticoid antagonist and an SGLT2 inhibitor. These are total game changers because they slash hospitalizations and, again, improve mortality. This sequence right here, it's pure high-yield gold. Memorize it.
All right, moving on to Section 2, acute decompensated heart failure. When those chronic issues rapidly spiral out of control, the pulmonary lymphatics get totally overwhelmed. Take a close look at the callouts at the lung bases here, showing that peripheral interstitial thickening. Those are your curly B lines. This brilliantly illustrates pulmonary interstitial edema. What you absolutely need to remember is that chronic heart failure patients might just show these lines on an X-ray, way before you hear a single actual alveolar crackle on your exam. But once that lymphatic clearance fails completely, that's when they tip into flash pulmonary edema. When a patient crashes, this stability algorithm is your lifeline. Follow the logic flow here. You've got to evaluate clinical stability first. If they're in respiratory failure, they get supplemental oxygen, non-invasive positive pressure ventilation, or they get intubated. If they're in cardiogenic shock, meaning severe hypotension, and their organs aren't getting perfused, you reach for inotropes like dobutamine or milrinone. Do not give standard vasodilators to a patient in shock. But if their blood pressure is normal or high and they're relatively stable, your immediate goal is dropping that preload. That means IV loop diuretics like furosemide, sometimes paired with a vasodilator like nitroglycerin.
Let's pivot to Section 3, high output and right heart conditions.
Usually, we think of heart failure as a low cardiac output problem, right? Well, in high output heart failure, the rules completely change. There are basically 3 main culprits here. 1, you've got an increased quantity of peripheral vessels, like we see in morbid obesity. 2, you're bypassing systemic arterial resistance entirely, which happens with an acquired AV fistula from trauma or dialysis. Or 3, massive vasodilation from unmet metabolic demands in the tissues, classic for hyperthyroidism or severe anemia. In all these scenarios, venous return drops, systemic resistance plummets, and the poor heart just literally cannot keep up with the hyperdynamic circulation. And we have cor pulmonale. This is specifically right-sided heart failure caused by a primary pulmonary disorder. And the absolute golden rule you must remember? The strict absence of left-sided heart disease. If the right heart is failing because the left heart failed first, that is not cor pulmonale. COPD is the most common etiology here because of that chronic hypoxic pulmonary vasoconstriction. When you're examining them, you're looking for JVD, peripheral edema, maybe a right ventricular heave, and a loud P2 that screams pulmonary hypertension.
All right, Section 4, high-yield cardiomyopathies. Let's see how this builds.
Just look at this anatomical comparison. It's really striking. On the left, a normal heart. On the right, hypertrophic cardiomyopathy, or HOCM. Notice that massive, asymmetrical, thickened septum just bulging right into the left ventricular outflow tract. And check out the anterior mitral leaflet. It shifts right toward the aortic valve during systole. That combo creates a dynamic obstruction of the left ventricular outflow tract. This is exactly why a young, otherwise healthy athlete suddenly presents with exertional syncope or a harsh systolic ejection murmur.
So how do we manage HOCM? It requires a highly specific approach. If they're symptomatic, you go with beta blockers or non-dihydropyridine calcium channel blockers. Why? Because slowing the heart rate increases diastolic filling time, which increases the blood volume in the left ventricle. That extra volume literally pushes that thickened septum away from the mitral leaflet, relieving the obstruction. On the flip side, you must avoid dehydration and vasodilators like the plague, because lowering that LV volume makes the obstruction significantly worse. Oh, and if they're at high risk for sudden cardiac death, like a strong family history or prior syncope, getting an ICD placed is absolutely critical.
Next up is peripartum cardiomyopathy. For this one, the timeline is quite literally everything. If you see rapid onset systolic heart failure, we're talking an ejection fraction below 45% in a pregnant or recently pregnant patient, check the clock. The diagnostic window is strictly from 36 weeks gestation up to 5 months postpartum, assuming there's no other identifiable cause. You treat it with a standard systolic heart failure regimen, but the timing is your ultimate diagnostic hook.
Another totally fascinating super high-yield one is Takotsubo, or stress-induced cardiomyopathy. The classic patient here is a postmenopausal woman who just went through a severe physical or emotional stressor. They roll into the ER looking exactly like they're having a massive heart attack. Chest pain, positive troponins, ischemic ECT changes, the whole shebang. But here's the kicker. You rush them to the cath lab, and there is absolutely zero obstructive coronary artery disease. You do an echo, and you see this left ventricular apical hypokinesis, famously known as apical ballooning. The good news? With supportive care, it usually resolves on its own in a few weeks.
And finally, Section 5, pericardial disease and trauma.
Cardiac tamponade is your prime example of obstructive shock, but the clinical presentation is all about the speed of fluid accumulation. In acute tamponade, which happens fast, over minutes to hours, maybe only 100 to 200 milliliters of fluid builds up. The pericardium hasn't had time to stretch at all, so this small amount creates massive pressure. That leads to Beck's triad, hypotension, JVD, and muffled heart sounds. But interestingly, their chest X-ray will show a completely normal cardiac silhouette. Subacute tamponade, though, takes days to weeks. The sac stretches out, accommodating 1 to 2 liters of fluid, giving you that classic, huge globular cardiac silhouette on the X-ray. So, keeping that idea of obstructive shock in mind, let's test your algorithmic thinking real quick. You have a patient rolling into the trauma bay after a high-speed motor vehicle accident, blunt chest trauma. They are hypotensive and completely hemodynamically unstable. What is your literal next best step? Focus right here on the left side of this pathway. For a hemodynamically unstable patient, you do not send them to the CT scanner. No way. You immediately do a bedside E-fast ultrasound, grab a portable chest X-ray, and get an ECG, while you're doing stabilizing interventions like placing a chest tube if they need it. If you still can't achieve or maintain hemodynamic stability after that, they are going straight to the OR for a thoracotomy. But what if that blunt trauma causes a myocardial contusion, a bruised heart? This is super insidious. The patient might just present with weird arrhythmias, anything from a few PVCs to full-on VFib. Now, listen closely, because this is a huge clinical trap. You naturally want to give IV fluids to a hypotensive trauma patient, right? But if they have a myocardial contusion, slamming them with IV fluids will actually worsen their elevated pulmonary capillary wedge pressure. Their bruised heart simply cannot handle the extra preload. These patients absolutely need 24 to 48 hours of continuous cardiac monitoring, because those fatal arrhythmias can pop up when you least expect them.
To sum up the core pathophysiology of cardiogenic shock in the trauma setting, just keep this definitive quote in the back of your mind. Cardiac contusion results in cardiac dysfunction with poor cardiac output. The pump is bruised, it cannot squeeze, and flooding it with extra volume is only going to back up straight into the lungs. Wow, we have covered a ton of ground today, all the way from the strict structured ladders of chronic heart failure therapy right into the high-stakes, split-second decisions of the trauma bay. But I want to leave you with a provocative thought that circles right back to a major physiological nuance we talked about earlier. Could a normal BNP completely rule out heart failure in your next obese patient? Think back to the mechanisms we explored. Keep relying on these clear, structured visual frameworks to build and guide your clinical intuition. Thank you so much for hanging out with me on this explainer, and I can't wait to dive into our next topic together.